Good evening, everybody. One of the important things is to start the year well. So you can never start a year well without wishing everybody a very happy and prosperous, mentally prosperous year for 2025 to each of you. My name is Rajan. I'm a former member of the Department of Surgery at St. Martha's. And one of the strokes of luck that happened to me is that I got training in thoracic surgery. So I was able to come back here and combine general and thoracic surgery, and this is the work that I was able to do. I'd like to thank Dr. Prem and his team of the EC, as well as Dr. Satyakrishna and the Department of Surgery for giving me this opportunity. What does the meaning of chest signify to the general surgical PG? Invariably, it is to put in a tube. And you find this macho PG coming in, ready to fire a gun, but a very, very frightened patient and an equally bewildered nurse not knowing what to do because there's so much lacunae in the knowledge of putting in a simple chest drain, which every general surgeon should be able to do. I'm going to talk to you in this whole topic, where each topic has a tip to make you remember, and a truth with which you approach the principles for treating that topic. In the basic surgical sciences section of thoracic surgery, the tip is anatomically we have two lungs, a right and left lung, and one heart. But remember, physiologically, there are two hearts and one lung, because the lungs do the same function, but each half of the heart does a different function, carries different blood and all that. So it's two hearts and one lung. And what is the advantage of that? That allows us to do single lung anesthesia. So you have one lung which can do the same work of two lungs. So that helps us to collapse lung, and that helps us to do surgery on the collapsed lung. So how we do this collapsed lung is by use of the double lumen tube, the tube that allows for single lung anesthesia. Double lumen tubes, there's a right and a left version. They have two balloons. One balloon occludes the bronchus. That is the distal one over here. That will occlude the bronchus. Over there you can see it occludes the bronchus. And the other one is like the traditional endotracheal tube, which will occlude the trachea. And you can clamp the tubes on either end at their exit point, and you will be able to collapse one side of the lung. These are how the double lumen tubes look like. The Robert Shaws and the Carlines are different varieties. But the most important gadget of this is the double lumen Y catheter that splits the air that comes from the endotracheal station, or that is the anesthetic station, into two pathways that go down into either side of the lung. This is how it looks in real life. Two tubes. You have the Y connector to each, and the end of the Y connector will have a small area where you can clamp. Can you see a clamp going across? So this chap's right lung is collapsed. It's clamped so that it's helping us to do surgery on the right side of the chest. So that is how you use the double lumen tubes. That is the clamp on the catheter. You have to know about imaging of the chest. You have to know how to read the chest X-ray. And a very, very quick, simple mnemonic is the SIP and the RIP. The SIP is to check your side, identity of the patient, position of the patient, and of the X-ray, and the projection. These are all things that are qualities of the X-ray that need to be corrected. I've seen decisions made on the wrong chest X-ray. I have seen decisions made with the side the wrong way. So don't let that happen. It sounds very silly, but it's important. And also you need to find out the rotation, the inspiration or expiration phase of the patient, and whether the penetration of the X-rays has been good so as to outline the lung fields. So this is how you look at the chest X-ray in a thoracic surgical angle. Learn to do it for all chest X-rays. The imaging of the chest, the way to image the chest is to use the mnemonic of ABCDE. This is the ABCDE that we look at: airways, bones, cardiac shadow and mediastinum, diaphragm, diaphragmatic angles, external soft tissues, breast, axilla, soft tissue, supraclavicular fossa, the fields of the lungs. They're divided into 3 zones, upper, middle, and lower zone. The gastric bubble, the hilum on each side, and whether there are any insertions or imaging or instrumentation that's been done into the chest, like a chest tube or something like that. What is very important, let me see, please, can somebody read the chest X-ray and tell me quickly what is wrong? What is the finding? If you follow my ABCD, you will be able to tell. Anybody? Almost everything is running normal, but you will find that there is a minimal rotation and an absent breast shadow. So this is a post-mastectomy, right mastectomy. Right breast is missing. You can see that that's the left breast, but this is a right breast is missing. This is a lady in whom there has been a mastectomy done. So the soft tissue there was giving you the clue. When you have X-rays of the chest, you need to count the ribs. Remember, you have to count them from the back, posteriorly. Don't try counting the anterior ends of the ribs. You may see 5 or sometimes 6 only. The rest will be behind the diaphragmatic shadow. So you always count from the top, from the neck of the ribs on the top. That's 1, 2, 3, 4. By the time you reach clavicle, you've already finished 4 ribs. 5, 6, 7, 8. You're almost into the lower chest. And 9, 10, 11, 12. 12 is invariably behind the diaphragm, so you have to count it like that. But it's easy to count ribs from posterior. There are different things for the imaging of the chest, and that one is the CT scan. And the CT scan will be able to give you a quick review of the transsectional imaging of the chest. And you have one with dye or without dye, and you have different windows. Windows in CTs are adjustment of parameters to make out whether a particular structure is to be seen better or not. So you have a bone window, wherein the bone tissues are seen out nicely. You can pick up fractures. You have a lung window, which is a very broad band of width between the CT imaging, which will make the bones very white, but the black features come out very nicely. The lung features come out. So that's the lung window. And then you have a mediastinal window, which will help you see the heart and the mediastinum. So these are the different windows that we use in the chest. That is the bone window. That's a lung window that sees the lung. See, you can't make out any bone patterns, but you can make out all the disease in the black. Here, you can make out the disease of the bones, but you can't see anything. The whole lungs appear black. So that's a bone window. This is a lung window. And this is a mediastinal window, which will help you to see the characteristics of the mediastinum. It doesn't give you enough information on the lung. The famous X-ray that everybody talks about is the HRCT. And the HRCT is a high-resolution CT only for medical lung disease. It was very good to get your COVIDs and other things diagnosed, but it is of no use to the surgeon. The surgeon needs to see the mediastinum and the bony cage. So that's why it is important not to go. Physicians will say, HRCT shows you this. Don't bother. You have to have your own CT to see it. And remember the various densities of the fluid. The fat is less than the fluid, so you'll always find it as air, fat, fluid, soft tissue, bone, and metal as the different amounts of staging of shadowing in the X-ray. It is important to take topographical views, different cuts of chest X-rays, and that is why if you see this looks like just a small loculated empyema on the transsectional view. But when you take a sagittal view, see how much of pus is collected inside. And when you take a coronal section, you see almost half the chest is full of pus. So don't go only on one view, look at 3 views for you to get a 3-dimensional approach to the pathology in the chest. Pleural physiology, the tip is that there are 2 layers of pleura, and intrapleural pressure between those 2 layers of pleura is negative. It's a very minute amount, it's a very small amount, about -4 centimeters. But that negativity is enough to help the mechanics of respiration. And what happens when substances collect in this pleural space? the pleural pressure become positive. And this pleural pressure becoming positive makes it such that it loses the lung, and makes the lung lose its effects of mechanical ventilation. And that is why breathing gets compromised. It's not only the mechanical effect, but it's also a physiological effect of preventing normal respiration from occurring in that lung. Restoration of the pleural pressures is the key to all thoracic work. Whatever thoracic work you do, ultimately you have to create the negative pressure so that the lungs will be able to work properly. And the tip for that is the underwater seal with an intercostal drainage. That is the key. Whatever you do in life, you may be the best oncological surgeon, you may be the best urologist, but learn that if you can put in a chest tube, you save lives. And you will get back the pleasure of breathing. It's when you're short of breath, you realize how much you need your lungs. So that important recovery is very, very satisfaction. So the truth is that the ICD is a lifesaver. We need to learn it. I'll go through those steps quickly. And one of the most satisfying things that you can ever have. I've got a couple of x-rays. I'll show you how it goes. ICD insertions, because it's the main thing in chest surgery, which you need to know. Everything is one of the, what shall I say, my kinks in my head is try to put everything to make it easy to remember. And my initials are CS Rajan. So almost everything I try to put it into these two letters, just to be a form of memory aid, so that you'll be able to read it properly. Two important things: corroborate the side and choose the site. I have seen chest tubes on the wrong side of the chest because they did not look and examine. A recently done chest X-ray or a recently done CT combined with clinical examination before you put in a tube. Very rarely for pneumothorax, but more commonly for effusions, because there will be pathologies on both sides and tube is gone into the wrong side. And choose your site. And for that, we have that very lovely safe area on the chest wall called the triangle of safety. It is bound by the lateral border of the pectoralis major, the mid-axillary line, and a horizontal line at about the 5th space. And into that space, you can always put in a chest tube, because the advantages are that the chest wall is very thin over there. You have no major blood vessels. You can do your dissection very comfortably. The lung always falls away from the chest wall at that point. You don't go, not worried about hitting the lung. Most comfortable position for the patient. Remember, if you put a tube at the back, he cannot sleep. He cannot lie down. It's very, very uncomfortable. So try and get it as far in front as possible. And the scar is cosmetic, gets hidden by either the breast shadow or the lateral border of the pectoralis major. So it is a very, very convenient, safe site to do it. The tips to insert: make sure that it is painless. One of our biggest mistakes, not yours, even mine, trying to put in the tube too much in a hurry. Locals not acting, the patient is going further and further away from you, and you are trying to bang in the tube. It is very, very mentally disturbing. It is like being stabbed when you're alive. So please, please, please be careful. Do it slowly. Do not use force. And if it is very urgent, the patient is breathless, stick in a needle thoracostomy, let the tension come out, and then do it slowly. Nowadays, you have Venflon catheters. Just put in a vasofix of Venflon, let the air out, and then you can do it slowly. You corroborate the site, I said. You choose the site. Give lots of local anesthetic. Among the only thing that is very easily available in all hospitals is local anesthetic. Take 10 ml or 20 ml of 2%, dilute it to 1%, and use it in the track, in the intercostal spaces around that area, so that you get also an intercostal block, then you get the local track area, and in front that you can do it. Copious amount. And wait for it to act. Don't take the needle, give it, and then start dissecting. So when you stopped it, given the local, turn around and set up your apparatus, your underwater seal, fill it with water, connect it all, make sure the connections are all ready and easily available, so that when you put the tube, everything can be done. Most often tubes go in and there's no tubes to drain. So you have to set it all up. While you set it all up, that local is acting. So when the local acts, you find that it is very easily done without pain. You have to sight it very carefully. You have to give the dissection, which is creating a shaft or creating a little space. Go up to the rib space and stop. Now you put in your sutures, you put in strong sutures. You put in a single mattress stitch in the middle of the wound, so that can be used to close the tract when you remove the tube. Keep it aside. And on the medial side of your incision, please put a simple stitch, which is called the securing stitch, which is used to tie up the tube and hold it in place. Dissect into the intercostal space now. You get in, you use a little force, reach the space and enter. The intercostal muscles are lying crisscross. So you need to put in there and stretch it open. You have to stretch it to create that track, create the hole. And God has given us that little finger. Put it in and make sure you've got a good track and an entry into the chest. Sometimes you're able to even do a finger sweep and see if any lung tissue is adherent there. Most of our patients, especially ladies, the chest space is much less. Your fingers don't fit through an intercostal space, so it's a little difficult. And when you're sure you've entered, guide the tube in. Not hold them. Don't do that, please. He'll never forget you. It gives them nightmares. Do it gently. It can be done gently. Just slip it in and guide the tube in. I do not like the use of stiletted tubes, because you all use stiletted tubes to do it as an instrument of piercing. The stillet is not for piercing. The stillet is, you create your track, and the stillet is to guide it in towards the apex or towards the base you want to. That's all it is. So that's how you should do it. Never, and how do you look after it? Sorry. Yeah, control soft X-ray, and then take a chest X-ray at the end of it so that you're sure that your tube is in place. Never clamp a chest tube, a bubbling chest tube. If it is swinging and when he coughs, if air is leaking, do not clamp them, because more damage done by the lung coming down and a clamp that is which is there. You can allow all movements to the patient. He can go to the loo, he can go for a walk, he can hold his tube, you teach him all that, and let them do all their physiotherapy. Here's a classical X-ray. This is from my hospital, where they had sent him down for a chest X-ray. And he had a bilateral tube, and somebody had clamped the tube on the left side. And as a result of that, the whole lung has gone down. The pneumothorax has come back. He was as breathless as before. So please do not clamp these the draining tubes, especially if they are bubbling. That is the lung that is collapsed. How to manage? Again, very easily, scrutiny of how you look after. It's again 7 CSS. Make sure there is a continuous swing. That means the tube is in communication with the negative pressures inside the chest. Make sure the connections are secure. Keep that underwater drainage constant so that the underwater seal doesn't get disrupted. Consider use of suction sometimes. You use spirometry, inspiratory spirometer. Big breaths, and also make them move that first ball for a long time. Not that big breath like that, just continuously move it. The lung opens out in the periphery. The alveoli that are collapsed all open out in the periphery. You commend that spirometry. You look for the X-ray improvement, and then you do a removal when you're sure the lung has come up. The complications, again, a very easy way to remember. It's all my initials again, very simple. Central structure injury. During the process, you go and jam it in too hard and you hit the mediastinum or the heart. I've had chest tubes inside the ventricle. I've had it inside the atrium. I've also had it in the liver. So these are the organs that can go. Crooked stationing, you put in the tube, especially in a thick-set person, you've done all the work, and then the tube has gone around the chest. It's not gone into the chest, because it's difficult. So make sure you enter the chest. You have to have, the tube gets blocked. If you don't frequently milk it and make sure it's patent, it tends to get blocked. You have to have it to be done properly. The tubes slip out of the chest. These tubes are long. Most often the patient stands on his own tube and moves, and the tube gets pulled out. So you have to make sure they're secured and fix it again. Some people develop a lot of crepitus, subcutaneous emphysema. It usually means that you've entered the chest in a place other than the place where you created the hole. You've got two openings there and you've got air leaking out. You may have to put another stitch in that place. Sometimes you get paradoxical effusion as a result of the, the lung again behaves as if it is of low oxygenation capacity, and that is because of the shift that occurs, the sudden mediastinal shift, which causes the paradoxical re-expansion pulmonary edema. So those things that just have to make it drain properly and give some IV fluids and some diuretics, they set down. And sometimes the tract can get infected. Sometimes you need the help of the CTVS people, and the two reasons are the lung is not expanding or the leak is continuous. Then you need their help to do some procedure. Otherwise, the general surgeon can manage it all. Now I'm going on to the thoracic trauma. I've got another 15 minutes to finish. Thoracic trauma is today's violent society, blunt and crush injuries, and you get penetrating injuries all over the place, always associated with either head injury or abdominal injury. And both of them increase the hypoxia. And when hypoxia is increased, the cerebral damage gets much more. The tip to note is the rule of two. The rule of two is you can die in the first 2 minutes of an accident. That is due to the trauma of the accident. You can die in 2 hours. It is this group of people that we can save. That is, they'll either have a tension pneumothorax or they'll have exsanguinating bleeding from an internal organ. They come to the casualty and then they die. So these are the ones that can be saved, and these are the ones that we should be looking out for. And the third is you die in 2 weeks. That means you've saved them from the casualty. They go into the wards, they get a wet lung, septic lung, and other things, and they die of sepsis. So this is how mortality occurs. So remember that 2 hours, the middle 2 hours, that are important. Always rule out the associated injury. These are the different types of chest wall trauma, anatomical basis. In the chest wall, you can get rib fractures, sternal fractures, shoulder girdle fractures, soft tissue contusions, and other bone fractures. You can get pleuropulmonary disease problems, that is the pneumohemothorax, the pulmonary contusion, the pulmonary laceration. You can get the diaphragmatic injuries with or without abdominal visceral injury. And diaphragmatic ones are the ones that give you a lot of trouble. I'm coming to that. And lastly, you can get mediastinal injuries. Mediastinal injuries are that first 2-minute injuries. Aorta has been torn off, they die immediately. Very, very rarely you get a chance to go in on a mediastinal injury because that is a major trauma and massive injury. The effects of trauma is that they impair ventilation, chest pain and shock, and hypoxia. The tip is the standard ABC of trauma management, airway, breathing, and circulation. But the main important is, remember, CSR. Calm the patient. They're restless. They're very agitated. They're scared. They can't breathe. They know something bad has happened. So give them a low dose of a sedation. Nothing happens. The thing of don't give sedation because of respiratory disease is wrong. You keep them calm in the mind, you get more an intravenous morphine 4 milligrams or a little 25 mg of pethidine IV and keep them quiet. Do a lot of suction, a lot of things collect in the throat because they can't cough and move, so suck it out. And remove the chest collections, that is put in an ICD. So this is what will save the patient completely. Oxygen, chest wall support and other things, then you can continue the hemodynamics. Remember that it is necessary sometimes to do a tracheostomy. You can do the tracheostomy for the patient if it is indicated. For imaging, remember first is the CSR again, a simple chest X-ray, lying down, supine X-ray, chest CT, supine chest CT, and a rapid fast, that is focused sonology for trauma. These 3 things need to be done in all patients. Now, in the trauma, the main thing that we deal is fractured ribs. A little word about how these fractured ribs occur. The truth is that the ribs can fracture as a single rib or multiple ribs, at a single site or at multiple sites, and they are the common at the curvatures of the rib. The ribs are fully curved, but they're more curved anteriorly and posteriorly, and that's where the fractures occur. So you can have a single site fracture, you can have a rib fracture at the two sides, and a segment gets dislodged, which gives us a flail chest, or you get fractures at three sites, and the whole rib gets pushed into the chest, the stubborn chest. So this is how you understand that. This is the simple picture of the rib, a curved structure. You can have a direct force on the rib and it cracks there, single rib fracture. Or you can have a compressive force on the chest and it can crack at the posterior angle, the most common part. The second one is you have the same but a little more trauma. You have the rib curvature over here. This is a rib curvature. There is a direct trauma and the ribs break at 2 points. Or you can have a compression trauma and that breaks the rib at the two angles. And this whole segment is flail. It's lost its connection to the synchronized movements of the chest wall. And that is why it's called flail chest. Or you can get the third type. The third type is where there is a direct trauma. The ribs break in 3 places. That is, these are the 3 places. There's 1, 2, and 3. And the whole rib is pushed into the chest wall. It occupies space. It causes a big difficulty for breathing, and that is called the stub in chest. So these are the 3 types of chest injuries that you can get to the ribs. The tip is the patient is always breathless. Crepitus. Crepitus is the main sign. You look for either the bony or the subcutaneous emphysema, air crepitus, and try and treat it. The truth is that look for the signs and rule out hemothorax, pneumothorax, the pulmonary contusion, and the pulmonary laceration, because ribs are always associated with some internal injury. The dangerous variety of pneumothorax is the tension pneumothorax, and that is the 5 T's. If you look at Manipal's textbook of surgery by Dr. Rajagopal Shenoy, he has given it. Patient will have tachypnea, tachycardia, tracheal shift to the opposite side, tympanic note. Don't forget, use your good old percussion, and a totally absent breath sounds. You can make a clinical diagnosis of the pneumothorax and you can act immediately. You can do a needle thoracostomy or stick an ICD. ICD saves lives. This is what I wanted to say. This is one of my Martha's PGs. He said, sir, pneumothorax, sir, big, completely collapsed lung, sir. I said, okay, man, I'm coming from home. I was staying in Aarti Nagar then. By the time I came from home, he's standing with me with this X-ray in his hand and waving, sir, fully cured, sir. So all he did was to put in a chest tube the way I taught him, and the lung fully expanded before I could even come to hospital. The relief on the patient's face was so much. He thought his doctor was a real hero because he restored that breathing, and that is a great satisfying thing. So make sure that this is a Martha's X-ray. He comes to the meeting. If that doctor comes, I'll introduce you to him. Srinivas Murthy was his name. You remember Srinivas Murthy, right? Yeah. So that is Srinivas's X-ray. Tension pneumothorax, the important thing is you cannot put the patient up many times, so you may have to read a chest X-ray on the supine position, and these are the signs that we have. We have the deep sulcus sign and a double diaphragm sign and a pericardial fat sign. So these signs have to be looked for. Please learn to read them. These are the pneumothorax signs. This is the double diaphragm sign. That is the diaphragm and the liver. They get outlined by the air there. It looks as if you have 2 diaphragms. You have the deep sulcus sign, the red arrow showing you the deep sulcus. And also you have the pericardial fat sign. And sometimes this pericardial fat sign, you can mistake it for the double diaphragm sign, which is the sign of continuous diaphragm sign, which is the sign of pneumomediastinum. So you don't mix up with that. Briefly about flail chest. This is a chest X-ray and CT of flail chest. Remember that it causes paradoxical respiration because it moves opposite to the direction the chest wall moves during respiration. And you get the two types of flail. Chest wall, front chest injuries where the sternum and the ribs break at the costochondral junction due to the steering wheel injuries, and that causes the anterior segment to move up and down. And the other one is the lateral due to multiple rib fractures. So in all of these, you need to stabilize the chest wall and then decide whether you need to fix it or it will settle down by an ICD only. The treatment given is urgent. Please be quick about it. Stabilize the chest wall. Simplest way to stabilize the chest wall, take a liter bottle of saline and put it on that one. That weight itself will prevent that segment from being flail. It gives you time to buy and put in a tube or do other things. So just prevent the flail and it will be very useful for the patient. The truth is that all flail chests, remember 6 Fs, you have fractures of many ribs, they're fractured at 2 or more points, the formal chest movements are lost, fails to fill the lung with air, so you get hypoxia. The fatality is very high, and fixation is sometimes needed. You need to go in and fix it. So that's the way you look at the flail chest. The stubborn chest is a place where the whole segment of the chest wall is driven in. These are also areas where there's a loss of lung volume, and that is, along with the contusion of that lung, makes the patient very hypoxic. So you need to treat it. And this more often needs surgery. You need to go in, lift the chest wall out, and fix it with multiple screws. All these dental plate screws, dental surgery screws, those sets you must get and use it to fix the ribs. Stubborn chest, the tip is that there are 7 S's. Smokers, if they are smokers, they get very badly affected. Several ribs open, broken, the whole chest is shoved inside the chest. Saturations are low, survival is at risk, surgery to chest wall needed, and screws and plates are used. So this is the way you can remember the features of stubborn chest. Both flail chest and stubborn chest come as very, very frequent short notes in all your theory exams. So just have an idea of what is happening. A big tip for you is to diagnose the hemothorax and the hemopneumothorax. Hemothorax is a whiteout. The complete lung gets filled up with blood and that appears white. Hemopneumothorax is you get a fluid level. There will be a small fluid level somewhere. Look for it carefully and you know that there's an air leak in addition to the bleed. So you need to treat that properly. Pulmonary contusion and lacerations. Sounds bad, pulmonary laceration. 90% of them settle down with simple ICD. And how did we know this? You know, there was an American war in Korea soon after the Second World War. And they were fighting there. And those Koreans were shooting these fellows up like mad. But there were no health facilities. And all the chest injuries, they used to put in a chest tube and fly them across the Pacific back to California or America. By the time they reached America, the lungs were completely healed. Just a simple chest tube. So every war teaches us something. The First World War taught us about antisepsis. Second World War about antibiotics. Third World War about the Korean War about chest tubes. There was a war in Nigeria, Biafra, there was a war where they used chemical bombing and caused a lot of burns. So our entire burns treatment is now related to how you treat burns by the exposure method, by that experience. Thank God there's not been a Third World War to learn something more, but we don't know. Anyway, so that is it. ARDS is a lethal problem for these people, and you need to treat them for various reasons. You get various words: stiff lung, shocked lung, septic lung, and other things. All these basically need positive pressure ventilation. Indications for thoracotomy, very rare. You need to take the thoracotomy into account. The high levels of blood loss, either by hourly or the whole amount of blood loss, you may need to open. Esophageal trauma, remember, is most often are iatrogenic. The scopes cause it. They cause it themselves. When they occur by themselves spontaneously, it's the Borhave syndrome. You have a group that occur in the chest where the Harman sign is positive with mediastinal flutter. Or you can also have it as the abdominal one where you have the Anderson sign triad available, where the tip is, where the perforation is in the diaphragmatic part or subdiaphragmatic part of the esophagus. Borhave is an interesting guy. He is the one who introduced clinical medicine, clinical teaching around the patient. So his history of medicine contribution is that. Finally, diaphragmatic injury. This is the dangerous fellow because negative pressure in the chest. At the time of incident, the X-ray will show nothing, but the rent will be there. And the negative pressure keep pulling abdominal organs into the chest. And then the patient gets into shock. So late shock occurring in a chest injury, think of diaphragm. Always do serial X-rays to make sure you're not missing a diaphragmatic injury. The last thing that we have to do is common thoracic surgical problems. Pneumothorax is air in the pleural cavity. I'm not going through all of them. It's a clinical diagnosis, and untreated it can lead to death. You have to see the degree of hypoxia and shock and treat it depending on the size of the pneumothorax. The types are simple and open, or close and suction, and tension. I spoke about tension. The classification on cause is either spontaneous, traumatic, or iatrogenic. Remember iatrogenic. And with our medical colleagues firing lines or subclavian lines and here and there, it's a very common cause of respiratory distress, so be ready to look for it. This is an important thing. Remember, pneumothorax is classified into 3, small, medium, and moderate and complete, depending on the distance from the chest wall. So that is the pictorial description of how the lungs look. Pneumothorax, very important one. If you want, you can take it down as when I finished it. Spontaneous pneumothorax can be primary or secondary. A small one, moderate or complete. And the small pneumothorax can be treated by observation. You don't have to do anything. Just watch them and take serial X-rays. But if you have a larger one, it can be aspirated. The negative suction, you can aspirate it. Moderate pneumothorax, you can try aspiration or you need the ICD. And complete pneumothorax, you will always need an ICD. The secondary pneumothorax, always an ICD. Secondary means there's some lung pathology, so you always need an ICD. Traumatic pneumothorax, always need an ICD. Iatrogenic, sometimes when they're small and the leak is stopped, you can go aspirate, otherwise it needs an ICD. This is the complete story of pneumothorax in one slide. So if you want, you can take a picture of it and you can continue. Next is empyema. Empyema is just a simple term for pus in the chest in various terms. Empyema thoracis, purulent pleural effusion. This is my story at St. Martha's. I have had about 400 odd empyema procedures at St. Martha's over 22 years. And that is the breakdown of what all that I had done. 402 cases in interventions. The empyema, the effects of empyema is all the effects of suppuration. There is pus there. So the patient will be ill, sick, high counts, LDH, everything will be high. And the mechanical effects of the cortex. The pleura gets thickened, and that prevents the chest from expanding, as well as prevents from lungs from filling. So that causes a lot of problems. The truth in the management is to drain, obliterate the space, investigate the cause, and restore pulmonary function. So these are your aims of treatment. The empyema, stage 1 and 2 with the low counts and other things, a simple tube thoracostomy, rib resection, or thoracotomy and drainage, completely replaced by VATS. Put in a VATS tube, suck it out, clean it out, put a tube and get out. VATS is video assisted. I used to do a lot of thoracotomy and thoracoplasties. These are some of the cases that I've had to deal. The rib resection, lovely operation. Before VATS came, remove a segment, clean up the chest nicely, drain it. It was very, very satisfying. This is the thoracotomy and drainage where the thickness is not coming out through ICDs. And this is the decortication that we used to do. This is my 83 cases of VATS, 6 needed conversion to open thoracotomy, and 6 more needed a further operation like a decortication or something like that. This is how we did the steps that we did the VATS drainage of empyemas. I have a video that will come up if there is time, but I don't think there's time, I'm running out. The truth is that the empyema diamond involves all forms of intervention for empyema. And that is, you aspirate and get a diagnosis, you can stick in a chest tube, ICD, or you can do a rib resection. Each of them, or after ICD, it goes This is completely the interplay of all the interventions for an empyema. Again, a good slide, you can keep it and see how it can be used. The surgeon, whatever it is, the type of intervention in empyema, tell them that there may be a second intervention and tell them the ICD is there for a long time. And here's one case of mine that went home, see how he strapped his ICD. He went to work as normal, but his pleural space was taking time to close. The greatest joy and satisfaction is the recovery of breath. Thoracic tumors, very simple, classify them by their anatomical layers. The truth is that the most common tumor in the lung is secondaries, and primary pulmonary tumors are either the small cell carcinomas or the non-small cell carcinomas. And nowadays, there are various classifications of neuroendocrine type of classifications. Mediastinal tumors, again, we have a mnemonic where it is 5 T's, the thymoma, the terrible nodes, teratomas, thyroid tumor, which is retrosternal goiter, and thoracic aortic aneurysms, which is the differential of the widened mediastinum. You do a mediastinoscopy and get your biopsy, and then do the appropriate treatment. Mediastinal surgery is very, very great, but video-assisted and robotic-assisted have taken over the mediastinum. Nobody's going through all that and doing all the surgeries. Remember, if you're doing thoracic surgery, 4 birds: vagus, ascigus, esophagus, and the thoracic duct. These are 4 chaps that will give you trouble when you do the surgery. So easy way to remember that. And thoracic surgical procedures, you always close with 2 drains. A is for the apex and end, B is basal and for the blood. The truth is very challenging, stuck planes, difficult surgeries, long time, but immediate result. You don't have to wait for patient to pass flatus. You know whether he's breathing or not breathing straight away. Scope of surgical surgery is huge. If my lectures helped one of you at least to go towards thoracic surgery, I'll sleep very happily. It is a vast and a huge topic of areas that need surgical attention. Very few surgeons. It is not popular because it involves a lot of hard work. But it is a big opening for you people. Urology, plastic, pediatrics, all filled men. There's still scope lying in thoracic surgery. So go for thoracic surgery, and I hope to wish you all a successful career. Thank you very much. As there's no time, I'll take questions outside.
So, on behalf of Surgical Society, I would like to thank Dr. Rajan sir for a wonderful lecture. And we have a lot of CSR in that, isn't it? Whom does CSR stand for?
Corporate social welfare.
So our own CS Rajan sir, he is a mentor. And I really think there will be at least 4 decades, sir, yeah, of work in this. It is a novelty for us, and you should really be lucky to be having such a golden opportunity to see this. And I think it was wonderful, sir. So, any questions, please? Right. Thank you again, sir. Thank you for the wonderful talk. Yes, sir.
It was an excellent talk. Thank you, sir. I request our president to hand over a small sapling as our token of affection.
We'll just take a break for towards the poster, and then we'll regather by 7:30. Thank you. Kumar? Yeah.
Uh, Good evening to all, and welcome to the first monthly clinical meet. It's indeed a pleasure for me to start again with my surgical canapes, which I had missed for some time. So I hope I will try to be more interesting. That's the whole idea of this surgical canapes. Surgical canapes means, literal meaning is snack. So it means we are giving snack in this academic feast. Okay? So let's start with the first slide, which I generally tend to put. This is the first slide I put. You can switch off the lights, I think. This slide is what you have to always remember, because there is plenty of noise out there. You have to filter which is scientific evidence, which is not. So you can see that in the non-scientific evidence, we have the YouTube videos, which is the first thing I think most residents log in and try to see, which is not a scientific material, evidence. Then we have personal anecdotes, then we have gut feeling, and then some guy you know. Okay, I heard, even recently we had an exam and somebody, where did you hear this? Somebody told. So these are not scientific evidence, so do not depend on those. And we have, in the hierarchy of scientific evidence, you can see the case reports, opinion papers are all placed the lowermost. These are the weakest in the whole hierarchy or the pyramid of the scientific evidence. Okay, and finally, as we climb the pyramid, we have a case control cohort, and finally all these meta-analysis and systematic reviews on which you are supposed to depend on. Okay, so now I have another my junior subordinate who's there giving sort of a company for me in this talk. I thought, let me try so that I'll get involved. A resident with me. Generally, it appears that one-sided talk and there's no participation, so we're trying to do a small experiment. Hope it works. Hi, your name is Nandan? Hi, Nandan.
Yes, hi, sir.
Okay, so let's start with my canapes. Nandan, what is one speciality of Bangalore?
Sir, I think currently Bangalore is a hub for the highest number of IT. So it is a tech savvy currently, and it is popular for many startups.
Very good. So Bangalore is known for startups. In the startups, we have one very unique feature which runs in the startup, which nowadays it's called as the lean startup. Are you aware of this? What is this lean startup? The lean startup means, as you can see in the first arrow, we have the, you can see the arrow going towards one goal. But at the same time, when there is a design and they build it, they test it. They take the feedback from the market, then they do changes which is needed, then again it continues. Okay? The cycle continues multiple times. So they're adapting to the market, which in the beginning they were in some enthusiasm, they sort of had an oversight, but as they started introducing and then realized, oh, this is what something modification has to be done, so they start with that. This is called iteration.
Sir, I have one question. How do we relate this to clinical research?
Yeah, so this is the first question which should come to you, that what is the relevance to us? We have something called as adaptive clinical trial. Okay, we have all heard of clinical research, clinical trial, but there is something called as adaptive clinical research, which involves or design that allows for modification during the study, okay, on the interim data. The adjustment or changes can be anything related to the sample size, dropping or adding treatment arms, modifying dosages, etc. If you're all aware, first we have to register in the Clinical Trial Registry of India, where we have to submit the whole protocol. Okay, the complete design. But here is something which is very unique called as adaptive clinical trial. But the standard still, the gold standard remains the classic conventional RCTs, which are having the complete fixed study protocol and culminate in a predefined analysis. So I'll just tell you how this is a good photo which you should remember. We just saw the iteration in the startup, very similar. You can see that the design, conduct, and finally analyze. Here you can see the design, conduct happens, then we are reviewing it, then again adapt, then again conduct, and finally we analyze. So it's a very unique thing which happens here.
So may I know what additional advantages does an adaptive design?
So it has got plenty of advantages and disadvantages. Advantages are very new, that is early study termination or dropping treatment arm due to if efficacy is problem or it is causing harm, we can stop. It will reduce the sample size, you can reduce the time to trial reporting. Now you will say, why are you reducing the time? Well, this adaptive clinical research came into very much highlight during the COVID times, where we didn't have much of time to wait. We never knew what will happen after 1 year. We need to do the trial very fast. 6 months, we had to change every month something new was coming. We had to adapt and finally submit the report so that the treatment can start. So this was one of the reasons. Of course, it has got its own challenges. It's very complex to design. It has got hurdles in the regulatory things. And of course, bias is there. And of course, the data monitoring, which is very much needed. It demands a robust system which is needed for that.
Sir, are there any studies done using this design?
Yes, there are plenty of studies which are already been published in various, whether it is CA lung or so in dementia and on. One of the very common, very popular trial is the I-SPY2 trial, which is for the carcinoma breast. You can log in, it is available, the whole paper, and you can check out about this trial, how the design has been done. So what you should think in your mind that it need not be fixed. Well, for example, I am a part of a scientific committee at my institute, so when they submit a paper, we ask you the complete protocol. We go through that and then tell them what is right, what is wrong. But here in adaptive, you can come back in between, take a 1 month, 2 months, and change, adapt something like that with a new design. And if you're more confused, we have ICMR conducting a regular basis web seminar. There are some recorded videos about that also, so you can log in and check out about the new thing. So with this, I jump to my second part of my canapes, that is blue sky thinking. Okay, blue sky thinking means thinking without boundaries, so without any inhibitions. So Nandan, you have been asking me questions, so I'll ask Nandan a question. Who is your favorite superhero?
So my superhero is Superman.
Okay.
Why did you ask this question? Sir?
So
Is there any
yeah,
relation?
it sounds very different that we are talking about superhero in a surgical meet, but this is, I'm trying to draw parallels between two different streams, superhero and surgical science. It is a metamorphical and a practical lens through which we can reimagine the future of surgical education, ethics, and innovation. By merging innovation science, it delivers highly engaging, intellectually stimulating, and forward-thinking and exploring the surgery's potential. So there are plenty of learning objectives. As I already told, it will stimulate new innovative thinking. We can think of what are the tech applied in the future. You can explore the ethical dilemma, futuristic challenges is thought. These are all written by fiction writers who have never had inhibitions, so they can imagine, whereas we have our own limitations in our brain. And then, of course, it fosters interdisciplinary collaboration. Enhancing public interest is very unique, and of course, mastering the situational awareness.
So what can we learn from this?
So you might say that, oh, come on, this is still ridiculous. It is still in the movies. I think you're just watching too many superhero movies and just talking about. No, I'm not just in fiction. It is in real life also. For example, bionic arm is existing. It is very similar to the, let's say, the hand of the Iron Man. It is something which is existing, which is available, used. So you cannot say henceforth that, oh, come on, it is just in movies. It is practically applied. Then we have something, you know, all this person in the Superman, the villain in the Superman, he is having those arms which is coming out. And the other side is a surgeon who is wearing an exosuit. Okay, the present exosuit probably supports only the ergonomic challenges, but maybe in future we'll have some hands coming out like that and helping us hold the camera, so no need for the cameraman. I mean, you can think whatever we can use. So this is possible, which was taught in the movie is already being applied. And apart from that, okay, let's assume the mind, physical, okay, let's go to the mind. Of course, one of the smart minds existing as of today, according to some, Elon Musk, he is doing this Neuralink. He's trying to create a cyborg. He's putting a chip in your brain, which always thought that, oh, come on, it is not possible. But he's one person who's really taking up something and showing us that, yes, it is possible. Okay. So what I'm trying to show you is that these are things which need not say that it is not possible, very much possible and in front of you. Just 1 second, we have a hitch. Okay, meanwhile, I'll continue. The next image, what I was supposed to put was that of Dr. Strange. Can Nandan say what is the special feature of Dr. Strange? You have seen movies? Dr. Strange, I think most of you are aware of Dr. Strange. So the Dr. Strange has got a capability that he goes into, multiverse, goes into different, analyzes thousands of possibilities, comes back and says, oh, this possibility is the best. I think this was in the end game also, I think, probably. So here, how are we relating to surgical field? It is what I spoke some time back, that something called as mental imagery. Every surgeon, I think, whoever is sitting, would have planned in his mind which is the best approach, which can be done, which has to be, sort of useful for us. This is the approach is good for that. What will happen? I'll prepare myself if something this happens. I'll keep that prepared or something like that. This is the possibilities. We are also thinking very similar to Dr. Strange. I don't know, unfortunately, we're not getting the slides. Because the slides are quite colorful and so Nandan, you can say which have you seen the new superhero movie which is going to come very soon?
I have not yet seen that.
Which is going to come? Okay, anyway, let's continue. Apart from that, I know this is conspiring against me. Hope it comes. Yeah, good. So the previous image was this, that Dr. Strange I put, and this is how the surgeon is also trying to see the possibilities, what can happen on table, and trying to think which is the best possible way. And then, of course, the favorite, many people's favorite is Iron Man. This, what he's doing is not augmented reality, but it's a mixed reality. And we already are having Apple Vision Pro with some surgeons or even operated wearing augmented reality. Still a possibility.
Sir, are there any studies on this?
Yes, so the next thing is that, of course, there are plenty of studies available. It is not that I am just building some sort of magic and trying to entertain you. This is science. There are publications. If you know, there is some Deadpool which had come recently who sort of regenerates himself, and there is Wolverine also who regenerates. Already regenerative medicine is being done. There is a 2023 publication, you can go through that. Here they have full detail on how this regenerative matrix has been created, is being planned. Wolverine, actually you can see that they're trying to accelerate wound healing. Very similar on what basis the Wolverine runs. And of course, it need not be stuck to only the physical things. We have something related to the mental also. I think many are aware of something called as knots. If you can see in the Avengers, the Captain America takes up this leadership role. Everybody has got role. He controls the whole team. So we have something called as knots, that is non-technical skill for surgeons. You have to look into that. So this is all very unique situations. We have NASA doing NEMO exploration, trying to do surgeries under the depth of the oceans, something like an Aquaman, plenty of comparisons. Of course, as I told you, it sort of fosters interdisciplinary collaborations, like material scientists can be collaborated to create vibranium, which is very much, everybody says is fantastic in the movies. Maybe we'll get a vibranium soon. There have been people who are using this to conduct classes also to teach anatomy for students, making it more interesting. So the question remains that what if the surgeon thought like Tony Stark or Bruce Wayne? And as young surgeons, you are more than a practitioner of craft. We all practice it, but you are more than a practitioner of craft. You are innovators in waiting. So the question is that, are you ready to think beyond the ordinary remains with you? You have to answer that. So we as a surgeon, with every incision and every stitch, we transform hope into healing. This is an image where we can see that, let's assume he's a doctor, he's fighting with the death and trying to save the patient. Thank you so much. Thank you, Nandan.
Thank you, sir.
I would like to invite Dr. Satyakrishna onto the dais. So without further ado, we'll start with the scientific papers. I would like to invite Dr. Harikishan Reddy. Harikishan Reddy for the first paper, and I would hand over the mic to.
Thank you. Welcome you all to the first MCM. As said, I thank the chair for giving us this opportunity. I call on Dr. Harikishan Reddy for the first presentation.
Good evening to respected President, Secretary, dignitaries, seniors and my colleagues. My name is Sarkishan Reddy. I am going to present a paper on intussusception in children. Breaking down intussusception in children, aligning findings with management pathways. Coming to introduction, intussusception first described in 1674 by Paul Barbet and first operated in 1899 by John Hutchinson. Intussusception is nothing but a invagination of proximal bowel into the distal bowel. Most common bowel obstruction is in the infants and toddlers. Most common type of intussusception is ileocolic intussusception. There are two types. One is primary, one more is secondary. Primary, most common is idiopathic. Secondary, most common is Meckel's diverticulum, followed by polyps or duplications, lymphomas, and other causes. Investigation-wise, we can do ultrasound. Most 90% of the cases we can confirm by ultrasound, wherein you can see in pictorial representation there is a donut lesion or target lesion appearance. And if not confirmatory with ultrasound, we can go ahead with the CT scan. There are two types of management. One is non-invasive procedure, one is surgical intervention. In non-invasive, pneumatic reduction and hydrostatic reduction we can do. And surgical intervention, laparoscopy, laparotomy, manual reduction or a resection anastomosis we can do. My aims is to study the demographic characteristics, clinical features of intussusception in children, to analyze factors that influence the need for surgical intervention. My study is a retrospective descriptive study done between 2017 to 2024, May, that is 8 year periods in St. Martha's Hospital. My inclusion criteria is all the children diagnosed with intussusception. Exclusion criteria is nil. My methods are all the data of the patients collected from the medical records department, demographic characteristics, clinical features, investigations, and operative findings and post-op follow-up details are validated and analyzed. And patients were divided into two groups: surgical intervention, non-surgical intervention. In surgical intervention, either manual reduction or resection anastomosis is done, and non-surgical intervention, pneumatic reduction done. In our institute, we will use a 14 French Foley's catheter or 12 French Foley's catheter with a Y connector, which is connected to the sphygmomanometer and the bulb. We will inflate the Foley's catheter with the bulb. You can see in the video, there is a class-shape appearance which will progress towards the bowel, and there will be a black color filling defect and immediate release of the air into the small bowel. That is confirmation for the successful reduction of the intussusception. My data was analyzed using SPSS window software, and chi-square test was used for qualitative data, and p-value set at 0.05 for significance. My results were total number of patients with intussusception were 33, age being 3 months to 9 years, and median age is 9 months. Less than 1 year are 17 patients, and more 1 year and above are 16 patients. Gender-wise, boys are 19 and girls were 14. That is a 1.5:1 ratio. Weight, highest is 22.5 kg and lowest is 5.4 kg. Clinical presentation-wise, most common clinical presentation is cry, pain abdomen or irritability, followed by vomitings, blood in stools, and loose stools, prior respiratory tract infection, and 2 patients presented with shock and peritonitis. Investigation-wise, we did ultrasound in 29 patients, ultrasound to CECT in 2 patients, directly CECT in 2 patients. There are 33 patients with intussusception, out of which 2 directly underwent surgical intervention. 1 underwent resection anastomosis, 2nd underwent manual reduction. Out of 33, 31 underwent pneumatic reduction, 19 were successful, and 12 were we have to convert into surgical intervention. Out of 12 surgical intervention, 9 were manual reduction and 3 were resection anastomosis. Out of 4 resection anastomosis, 2 patients had gangrenous bowel segment with peritonitis, and 1 patient had a Meckel's diverticulum, and 1 more patient had colonic intussusception with juvenile polyp. We had 1 recurrence out of 33, that is 3.03%. In this patient presented with a long segment of intussusception till the sigmoid colon in first presentation, reduced by pneumatic reduction, and recurrence after 1 month is noted, and extent till transverse colon was noted in the second sitting, and again reduced by pneumatic reduction, and follow-up patient is doing well up to 6 months. Coming to analysis, we analysis age that is below 1 year and 1 year and above. compared between surgical intervention and pneumatic reduction, which is not significant. Coming to gender, females and males, there is no significant difference between surgical intervention and pneumatic reduction. And coming to duration of symptoms, that is less than 72 hours or more than 72 hours. We compared between surgical intervention and pneumatic reduction. There is significant difference between both the groups. And the extent of intussusception up to transverse colon and beyond transverse colon, we compared between surgical intervention and pneumatic reduction, but there is no significant difference. Coming to the discussion, intussusception is the most common emergency in the infants with male predominance. Children mostly present with pain, cry, irritability, or blood in stools and gastroenteritis features. This is the most common abdominal emergency in the infants. More than 90% of the patients are presented with idiopathic, and 10% remaining the secondary cause. In our study also we noted that 94% of the patients are had with idiopathic, and other 6% had one had a Meckel's diverticulum and another had a colocolic intussusception with a juvenile polyp. And in our study we observed that when we compared between surgical and non-surgical groups, there is no significant difference between age that compared between less than 1 year or more than 1 year, or extent more than transverse colon, beyond the transverse colon, or below the transverse colon, and between genders, males and females. But there is significant difference between surgical and non-surgical intervention when compared between duration of symptoms, that is less than 72 hours and more than 72 hours. Our study has a similar results like Thanjon et al. And Leonard et al. In aspects of gender, age, and extent of intussusception and duration of symptoms. And I like to conclude that age, gender, extent of intussusception did not influence the need for surgical intervention, but delayed presentation to the hospital with intussusception had increased rate of surgical intervention. These are my references. Thank you.
Thank you, Dr. Harikrishna. The paper is open for discussion.
Nice presentation. A few comments.
Yes, sir.
The first thing is your definition. You defined it as proximal loop going into the distal loop.
Yes, sir.
The correct thing is one loop going into the distal, because you can have a distal loop going into the proximal.
Okay,
First thing. The second thing is you see you're given the investigation and all that. Most important thing is the clinical presentation.
yes, sir.
Current jelly stools, sausage-shaped mass,
Yes, sir.
Sindy dance. These are the few things. See, we are after all, it's a clinical diagnosis. Then, of course, your ultrasound may confirm or that.
Yes, sir.
Third thing is, when do you take up these patients for pneumatic this thing, or when do you take it for surgery? So, if there is a delay of more than 72, do you do pneumatic on all the cases, or you choose, depending upon the time of presentation?
If patient presented with shock or any peritonitis symptoms, we will go ahead with laparotomy or laparoscopy, sir.
Otherwise?
Otherwise, all the patients will undergo pneumatic reduction, sir.
Duration is not the criteria which you take.
No, sir.
So peritonitis is the one.
Yes, sir.
Okay, how many times you have done laparoscopy in this particular patients? Laparoscopy?
Total laparotomies were...
You said you will do laparoscopy or laparotomy?
yes, sir.
How many had undergone laparoscopy?
Total were 14, sir. Out of 14, we did 6 laparoscopy, sir.
Success rate on laparoscopy?
100% success rate.
Thank you. A good presentation.
Thank you, sir.
This is about your results. You have concluded saying that duration of presentation
Yes,
affected your results.
yes, madam.
That surgical intervention increased.
Yes, sir.
So have you compared and given p-value for that?
Yes,
Was the difference significant? I don't know whether I missed
Yes,
it.
madam. Yes, madam. This is the...
So whether this was, okay, so you have given a, sorry, I missed that. And your objectives.
Yes, madam.
This is just a comment this is probably for all PGs also. When you write objectives, now you have given a conclusion of all the factors that determines the outcome,
Yes, ma'am.
right? So in your aims and objectives, you should simply say this study is to determine the factors that influence the need for surgical intervention. You shouldn't start with the study or to study the demographics.
Okay,
Okay, demographic means it becomes to the entire community, and it's a huge thing.
Okay, madam.
So if you can, because when you write these things, your acceptance in your journals will be high.
Okay,
It's
madam.
just for your information.
Okay, madam. Thank you.
Okay, thank you, Dr. Harikrishnan. Thank you.
Thank you, everyone.
I call on Dr. Sreekar Reddy for the next presentation.
Good evening, all chairpersons, seniors, and all. Today, I like to present about comparative analysis of IPOM and ETPRS for umbilical hernia. Usually, ventral hernias are a common conditions affecting about 20% of adult population. Among all, umbilical hernias are most common, which imposes significant burden by reducing the quality of life. If untreated, they will present like with a condition like incarceration, strangulation complications, which leads increase in mortality rate compared to elective cases. Various surgical approaches are there, both laparoscopic and open approach. The various minimal invasive techniques introduced in which placing of a mesh in different layers is different in different techniques. In IPOM, we place mesh in intraperitoneally, in ETPRS, in recto-rectus plane. Various other laparoscopic hernia repair techniques are Melos or Emelos and TAP, TARM, and SCOLA. In IPOM, we use the standard 3-port technique, initially using various needle. Pneumoperitoneum is created, followed by primary port placed in Palmer's point. Under the initial diagnostic laparoscopic being done, under vision secondary ports being placed, and release the hernial sac and excise the sac, and mesh is placed and fixed with the transfacial sutures and absorbable tackers. In ETPRS, preoperatively seminolar lines and subcostal margins are being marked. First initial port we placed medial to seminolar line and insufflated the Nemo. Created in recto-rectus plane, and secondary port release the loose areolar tissues by the camera port, and secondary ports being placed under vision. Superior crossing over being done by making an incision on left posterior rectus sheath, then releasing the falciform ligament to down, and entering into the contralateral recto-rectus plane by making incision over the right posterior rectus sheath, and releasing the posterior rectus sheath cranially, we will reach the defect size, and followed by reducing the contents, and lateral we will release the posterior rectus sheath caudally also. Followed by we will visceral sac being closed with vicryl without tension. Mesh is placed in the recto-rectus place and fixed with non-observable tackers. My aim is to compare the outcomes of IPOM and ETPRS for umbilical hernia. My main objective is to compare the intraoperative parameters of IPOM and ETPRS and compare the incidence of postoperative complications. It is a prospective study done at St. Martha Hospital in 1-year period group. Randomization is being done by using odd and even method. Microscopic Excel, unpaired t-test, and fissure extract test being applied for their statistics. Ethical committee being approval being done. My main inclusion criteria is age more than 18 years, patients who undergone elective laparoscopic mesh repair for umbilical hernia and defect size less than 3 centimeters. Exclusion criteria is patients who are not fit for general anesthesia and not willing for laparoscopic mesh repair and emergency hernia surgeries, and patients with divercation of recti. My total sample size is 50, 25 in each group, and there is no gender predominance, and mean age group of 50.72 years in IPOM and 45 years in ETPRS, and mean BMI of 27.01 in IPOM and 26.78 in ETPRS, with a mean defect size of 2.2 centimeters in IPOM and 2.6 centimeters in ETPRS. Coming to intraoperative operative duration with a mean 74.40 in minutes in IPOM and 171.8 minutes in ETPRS with a significant p-value. 1 out of 25 cases in ETPRS converted to other procedure, there is no conversion rate is seen in IPOM. Post-operative pain being measured by using mean VAS square on POD 0 after 12 hours of surgery, and POD 1 and POD 7 and POD 30. And POD 0 and 1, there is a significant p-value, and after 1 week of interval, there is no significant p-value, and the POD then there is no significant difference between two. Coming to the hospital stay, there is no significant difference in hospital stay, 2.84 days in IPOM and 2.60 days in ETPRS. And coming to the post-op complications, incidence of seroma, 2 out of 25 cases are noted in IPOM, and 1 out of 25 cases are noted in ETAP-RS. Incidence of hematoma, 1 out of 25 cases are noted, seen in ETAP-RS, and post-op ileus, 2 out of 25 cases have been noted in IPOM. No SSIs and misinfections been noted in both the techniques, and 2 out of 25 cases been readmitted in ETAP-RS, and there is no recurrences seen in 6-month follow-up. The laparoscopic techniques have an advantage of shorter hospital stay and early resumption of work and lesser surgical wound complications. Both IPOM and ETAP both are minimally invasive procedures in which differs in placing of mesh in different positions. It is a prospective study done with a sample size of 50, 25 in each group, with a mean defect size of 2.2 centimeters in IPOM and 2.6 centimeters in ETAP-RS. These are my results in our study showing that correlating with other studies which show similar results in view of hospital stay, operative time, and post-operative duration. And conversion rate, SSIs, and incidence of seroma, and incidence of hematoma, and post-op ileus, and incidence of readmissions be noted. See, in IPOM, it is a faster procedure with lesser dissection, and it is feasible to place mesh easily, and it shows highly reproducibility. ETAP-RS is a longer procedure with more dissection with lesser early post-operative pain, and observed that ETAP-RS being the learning curve is steep. I like to conclude both have their own advantages and disadvantages. In IPOM, we have lesser operative time, more early post-operative with the incidence of seroma and ileus. In ETAP-RS, longer operative duration, which improved with that time, and lesser early post-operative pain with the incidence of hematoma. My main limitations are limited follow-up period, small sample size, and small defect size. These are my references. Thank you.
Thank you, Dr. Somsekhar. The paper is open for discussion.
Which has a higher incidence of strangulation or obstruction?
Incisional hernia is one.
Incisional hernia. Just a theory question. Second thing is, in the procedure for ETAP, you said you mark the semilunar line.
Yes.
How do you do that?
Ultrasound guidance.
So you should mention that, isn't it?
Sorry.
So every patient underwent ultrasound.
Ultrasound, preoperatively ultrasound guided semilunar lines are markers.
Okay. Thirdly, what is a consensus recommendation for a ventral hernia defect of, let's say, 2 centimeters and less?
So usually...
No, I'm talking about consensus. Recommendation.
Recommendation less than 2 centimeters
hernia
without
society.
asymptomatic...
But the hernia society,
yes, sir.
whichever you want to say.
Less than 2
Asia-Pacific.
centimeters, we go with anatomical repairs.
So what would be the indication for laparoscopic repair?
Sir, patient presented with symptomatic...
No, I'm talking about, is there a size criteria?
I have no idea. Sorry.
And lastly, you look at IPOM, you have intraperitoneal placement. So
Yes, sir.
the problem with IPOM is you need to have a longer duration of follow-up
Follow-up, yes, sir.
to look for additions, particularly intestinal additions. That is a major, and also post-operative pain.
Yes.
I mean, we have seen IPOM patients with transfacial sutures and tackers having pain for a longer duration of time. I'm surprised that there's no difference between the two groups.
Thank you. Very good presentation. What is the reason for readmission in ETAP cases?
Sir, initially, initial days of ETAP-RS, there is an posterior rectal dehiscence is there. Patient presented with subacute intestinal obstruction. We had a diagnostic lab, and due to posterior rectal dehiscence, the bowel got adhered to the mesh, and we converted to open. Second readmission due to hematoma, conservative management we did.
I think that's a major complication. You should mention that.
Yes, sir.
Which did not occur with IPOM plus.
Yes,
Thank you, Dr. Somsekhar.
Yeah.
Just a comment.
Yes.
You said I think 5% of the population has got umbilical hernia, right? I think in the in the first slide which you put.
20% of
20%.
of adults, sir.
20% of the population he has mentioned. Huh?
Yes, sir.
Is that what you have said? 20% of the population you have mentioned. Please see. No, it is not possible. The most common hernia is the inguinal hernia, which occurs in about 2%
So
of
first
the people.
inguinal hernia followed by umbilical hernia, sir. Most incidents.
What? 20% is a lot of this thing. And the second thing is what type of mesh you use in either case?
Sir, in IPOM we use a dual mesh intraperitoneally. In rectus polypropylene mesh.
That's what you must mention because that is the main thing, the cost
sir.
saving.
Yes.
Although you spend so much time in the OT,
Yes,
you are
sir.
saving the cost.
Actually, there is a cost difference will be there, sir. But nothing to be done. All the patients.
Yep.
No, one
Thank
of the
you, sir.
indications is.
Thank you,
Thank
sir.
you, Dr. Somsekhar. I call upon Dr. Nandan to present his paper.
Good evening. So I'll be sharing our experience with radiofrequency ablation in the treatment of varicose veins. So varicose veins are dilated tortuous veins whose primary cause is non-functional valves with decreased elasticity in the vein walls, which results in venous reflux. Symptoms can range from leg pain, swelling, throbbing, cramps, leg fatigue, itching and burning. Formation of ulcers represents the endpoint of venous insufficiency, and 20% of the patients will require intervention at some point. So CEP classification 2020 is used for reporting and classifying the disease, and ultrasound, duplex ultrasound is the optimal investigation of choice for the diagnosis. So this table represents the CEP classification. However, this is useful only for classifying the disease, and it is of less importance when it comes to following up the patients, comparing preoperative and postoperatively. So hence, we use the Venous Clinical Severity Score, which contains 10 domains. So primarily, the treatment for varicose veins is, the definitive treatment is surgical. However, medical is only for symptomatic relief. Earlier, stripping of the vein was the gold standard for varicose veins. With the introduction of endovenous procedures, currently the gold standard is endovenous procedures, which again includes non-thermal and thermal procedures. Non-thermal includes sclerotherapy or cyanoacrylate glue injection or mechanico-chemical ablation. Thermal tumescent procedures include laser ablation, radiofrequency ablation, steam vein sclerosis, and microwave ablation. Radiofrequency ablation is an image-guided procedure which uses heat energy for thermal energy is delivered either through bipolar or monopolar electrodes. So this heat energy produces transmural death of the vein wall, which results in permanent fibrosis of the vein segment which is being treated. So the first image is a pictorial depiction of the way the catheter works. The second image shows the tip of the catheter, which is the active part of the catheter. So the aim of our study was to study the outcome of radiofrequency ablation in the treatment of lower limb varicose veins. So this was a prospective observational study done over a period of 3 months, ranging from October 2023 to December 2023. And patients were followed up till December 2024 over a period of 1 year. All patients consenting to undergo RFA procedure were included in our study. And all patients with a great saphenous vein diameter more than 1.2 centimeters at the saphenofemoral junction were excluded from our study. So our study consisted of 31 individual limbs of 23 patients. 15 were unilateral and 8 were bilateral. Intra and postoperative complications were studied, and patients were followed up at 5 days, 1 month, 6 months, and 12 months to evaluate the outcome. So the primary outcome in our study indicated GSV closure at 1 year. Secondary outcome indicated failure at 1 and 6 months. Also, the pain score and VCSS score was compared. Successful ablation in our study indicated that Doppler done at 1, 6, and 12 months showed a complete occlusion of the great saphenous vein. And failure indicated that a segment more than 5 centimeters still demonstrated patency. So the procedure is done under spinal or general anesthesia under ultrasound, on-table ultrasound guidance, so with the vein being accessed just below the knee joint with an 18-gauge needle, following which a 7 French sheath is placed, through which the catheter is introduced into the vein and advanced up to 2 to 2.5 centimeters from the saphenofemoral junction, following which tumescent anesthesia is injected all around the vein, which helps in collapse of the vein over the catheter and also prevents heat dissipation to surrounding tissues. So ablation is carried out with segmental pullback of the catheter. Heat energy is delivered at 120 degrees Celsius for a period of up to 20 seconds. All our patients also underwent adjunct procedure with foam sclerotherapy and also mini phlebectomy done as required. So this is a video demonstrating the introduction of the guide wire into the vein with ultrasound guidance, following which a sheath is introduced and catheter is placed. Tumescent anesthesia is injected under ultrasound guidance, following which ablation is done at 120 degrees Celsius with segmental pullback of the catheter. So this image shows the preoperative and postoperative image of patient treated with RFA. So coming to the results, 23 patients were included in our study with 31 limbs. 15 subjects were aware of the varicose veins for more than 5 years, and only 1 patient was asymptomatic. Pain was the most common presenting symptom in 54% of our patients, followed by pigmentation and lipodymotor sclerosis. 8 patients had history of ulceration or bleed, and preoperative venous clinical severity score ranged from 3 to 21 with a mean of 7.97. All the patients had the great saphenous vein being treated, with 9 patients also being treated for the anterior accessory saphenous vein and 2 patients being treated for short saphenous vein varicosities. Duration of procedure ranged from 26 to 42 minutes. All the patients also underwent concomitant treatment with foam sclerotherapy, with 14 patients also undergoing mini phlebectomy. 4 patients had foam sclerotherapy of the dilated anterior accessory saphenous vein, and 2 patients for the dilated short saphenous vein. So this is a pictorial depiction of gender distribution and the most common presenting symptoms. So the clinical CEAP score at presentation, most common patients fell into the group of C4B, following which 6 patients also had ulceration. Intraoperatively, complications were infrequent. Only in 2 patients, a second puncture was required above the knee due to tortuous vein and inability to pass the fiber up to the saphenofemoral junction. Immediate complications from post-op day 1 to 5, pain was the most common complaint, followed by phlebitis and ecchymosis. At 1 month, still 6 patients continued to have pain, followed by 5 patients having ecchymosis, resolving ecchymosis. At 6 months, only 1 patient had pain, but there was significant reduction in pain compared to preoperative pain. So CEP classification, preoperatively and postoperatively, there was all the patients with ulceration had healing of ulcers, but there was no significant change in CEP score. So pre-op VCSS and post-op VCSS was used. There was significant change from mean of 7.97 to a mean of 3.3 post-operatively. At 1 year, all 31 patients showed complete occlusion of the GSC with no signs of recurrence, and the VCSS had improved post-operatively. This image was healing of ulcers. So advantages, it is a minimally invasive procedure with faster mobilization and less morbidity and recurrence rates. However, long-term follow-up is required. Current gold standard for varicose veins is endovenous procedures, with closure fast being the new generation catheter, with significant improvement in the ease of use and procedure speed. These are my references. Thank you.
Thank you, Dr. Nandan. The paper is open for discussion.
This is a combination of 2 procedures, right? Foam
Yes, sir.
sclerotherapy. So it's not one alone.
So, but yes.
Neither laser alone or foam sclerotherapy alone, right? It's combination. So second thing is, what is the use of, for the sake of the PGs, what is the use of the anesthesia, tumescent anesthesia? How does it help?
Sir, it helps in collapse of the vein over the catheter, so there is better delivering of the heat to the vein walls. Also helps in prevention of heat damage to the surrounding tissues.
Yeah, heat sink.
Heat sink.
What is Mickey Mouse sign?
Sir, it is seen on ultrasound in great saphenous vein varicosities, where the femoral vein and the saphenous
Not
vein is
varicosity, it is junction of.
junction.
Junction.
Yes.
So you look at results just tell us what results from the literature that you have between surgery and minimally invasive procedures, endovenous procedures, at 1 year, 5 year, 10 years. Do you have any idea? Not looking at the results that you have projected, because it's too short a follow-up, but
Sir,
from literature.
Yes, the literature says there is 98%, close to 98% success in endovenous procedures compared to open procedures.
At 5 and 10?
Yes, sir.
All?
Yes.
Okay, good presentation.
What happens to the branches that we usually, when we do the open procedure, there are 3 named and sometimes unnamed branches. So what happens to those? The tributaries at the saphenofemoral junction. See, the belief is that despite doing a very good procedure, if you don't identify all the the branches that join the SFJ, that is one of the reasons why there is recurrence. So with this, what happens to those branches? Do you do anything about them? No.
So since it is an ultrasound guided procedure, we also do either foam sclerotherapy or mini phlebectomy as required if there are many tributaries.
You're right.
We don't
Thank
go
you,
above the level of the junction, okay?
Yes.
And these are all smaller veins, relatively. So the
Sreekar,
outcome
one
is slightly
comment.
better.
No, you did it from the level of below the knee, right?
Below the knee.
What about that which was at the leg? The vein at the leg. What was done for that?
Foam sclerotherapy we did, ma'am.
For the entire
Entire
part of the vein in the leg,
In
that
the
is
leg.
from the knee joint to this.
In lower.
For all the
triangle.
patients with
For all the
radiofrequency.
patients. Yes.
It's ultrasound guided.
So ultrasound guided, we introduce it inside the vein. It goes, sir. Sir, that's why in 2 of our patients we had to do an additional puncture above the knee joint since it did not go.
No, because in radiofrequency, that is the advantage over the open surgery, that you can do this from the level of the ankle joint, that is from the beginning till up to the junction. So that is the advantage. And surgery we avoid because we will strip off the nerve.
Right. Thank you, Dr. Nandan. I call on Dr. Pallavi to present her paper.
Good evening, respected dignitaries and my colleagues. My paper is on the role of indocyanine green in laparoscopic cholecystectomy. With the widespread introduction of laparoscopy in cholecystectomy, there was noticed an increased incidence of CBD injuries. There is role for intraoperative cholangiogram to identify the extrahepatic biliary structures, but it comes with its own cons like cost and radiation exposure. So a recent alternative to the routine IOC is the use of near-infrared cholangiogram, which is ICG assisted, to facilitate the dissection without requiring to cannulate the cystic duct. It can either be given directly intravenous or into the gallbladder and visualized with the infrared light. With this in background, we conducted a study to test the efficacy of indocyanine green in laparoscopic cholecystectomy in improving the anatomical visualization of the extrahepatic biliary structures. Our secondary aim was to compare the intraoperative and postoperative outcomes in patients undergoing either ICG guided or without ICG guidance laparoscopic cholecystectomy. We compared the patients under the following categories, including the indications, preoperative difficulty, the visualization of structures, and the intra and postoperative outcomes. This is a prospective comparative study conducted in St. Martha's Hospital over a duration of 1 year with a minimum follow-up 1 month. 100 patients were taken for the study and alternately randomized into the either groups. They were assessed with the appropriate tests, and a p-value of less than equal to 0.05 was considered significant. Ethical committee clearance was taken, and all patients aged more than 18 years of age undergoing laparoscopic cholecystectomy with general anesthesia were included in our study. Then after, we divided all the patients into 3 groups, that is easy, difficult, and very difficult, based on the modified Randhawa-Pujari scoring system. It should be noted that any history of previous cholecystitis, cholangitis, or ERCP, it holds a point value of 4 points. All the patients were administered indocyanine green intravenously minimum 12 hours prior to the surgery, And the camera was equipped with light source which emits both visible and near infrared light. Patients underwent standard 4-port laparoscopic cholecystectomy thereafter. Here are some of the examples where under the white light source, we are not able to clearly delineate the cystic duct, whereas with ICG guidance, even prior to the dissection, we can recognize the location of the cystic duct. Some cases where under both white light as well as under indocyanine green visualization, it is easy to identify the cystic duct. Some cases where there were adhesions to the gallbladder, it is difficult to visualize the structures both under white light as well as ICG guidance prior to starting the dissection. Once after dissection, we have achieved the critical view of safety. We can identify the cystic duct with the help of ICG and confirm it. Our data was then tabulated in the following manner, that is the visualization of cystic duct and CBD prior and after dissection, both under ICG and white light guidance. Coming to the results, we noticed the female preponderance in our study group. The most common indication for surgery was symptomatic cholelithiasis, followed by acute calculous cholecystitis. Based on the difficulty, most cases fell into easy group, followed by difficult and very difficult. We noticed a similar distribution of cases in either of the group. In cases with easy preoperative scoring system, we noticed that prior to dissection, we were able to delineate the cystic duct and CBD in 70% and 30% cases, whereas after dissection, all the cases confirmed cystic duct was visualized and half the cases CBD was seen. We noticed an increased visualization in these structures under ICG guidance. The p-values were significant except for dissection, after dissection cystic duct visualization. We noticed a shorter operative duration and shorter time to achieve the critical view of safety in these cases. Similar result in difficult preoperative scoring system, where there was increased visualization of the structures under ICG guidance. One of the cases was converted into laparoscopic subtotal cholecystectomy under white light source. Decreased operative duration and time to achieve critical view of safety was also noticed. In the very difficult score, none of the cases we were able to visualize the extrahepatic biliary structures either under ICG or white light. But after the dissection, in 2 out of the 3 cases in ICG, we were able to confirm see the cystic duct and CBD. And under white light source, only 50% of the cases we were able to visualize the structure. This was mostly due to adhesions to the gallbladder and the Callet's triangle. Gallbladder wall edema also played a role. The patient outcomes, overall, there was increased incidence of conversion to open cholecystectomy in white light source, increased incidence of subtotal cholecystectomy as well in white light source, but the results were not statistically significant. I would like to highlight that we encountered cases which were easy as per our scoring system, but we encountered increased intraoperative difficulty. Hence, if the facilities permit, it is recommended to administer indocyanine green in all the cases where we can identify the normal structures or aberrant variations. And with meticulous dissection, it allows a better identification of the extrahepatic biliary structure. There is also role of intravenous indocyanine green, which helps to visualize the arterial structures, but we didn't encounter any such cases in our study. On comparison to other studies, we had similar results regarding increased visualization and regarding the operative duration, conversion to open, and incidence of subtotal cholecystectomy. I would like to conclude by saying indocyanine green improves the qualitative assessment of the extrahepatic biliary system during laparoscopic cholecystectomy, and we noticed less rate of conversion to open procedure and incidence of subtotal cholecystectomy in the ICG group, but the results were not statistically significant. The drawbacks were the limited number of patients. I would like to say that near-infrared cholangiogram is an easy-to-perform adjunct or tool which allows the surgeon to repeatedly visualize the biliary tree and helps to simplify the critical view of safety, thereby preventing biliary duct injuries. These are my references. Thank you.
Thank you, Dr. Pallavi. The paper is open for discussion.
No, ma'am. We divided the patients alternately in either groups, and after the scoring system, we noticed the similar distribution in either of the groups, ma'am.
There was it was an unbiased one.
No, ma'am. So we use a dosage of 5 milligrams, sir, and this is done at least 6 to 12 hours prior to the surgery. We came to this dosage after a hit and trial, where we tried different doses for different patients initially, and wherever we noticed the highest liver to bile ratio, we started using that dosage for all our patients.
What was the cost for this, just for information?
Ma'am, the indocyanine green itself in our hospital, it comes out to be 1500 per vial. And if there are multiple cases, that dose can be used for up to 5 patients in the single vial. So the cost cuts down.
Thank you.
Thank you, Dr. Pallavi.
Thank you.
I call on Dr. Subba Reddy to present his paper.
Good evening, everyone. I'm going to present a paper on urinary tuberculosis, which is still a challenge. In India, tuberculosis is one of the leading causes of morbidity and mortality. It is an important public health concern. According to Global TB Report 2023, India's estimated TB incidence per 1 lakh population is 195. Genitourinary TB in patients of extrapulmonary tuberculosis is nearly 14 to 41%. The incidence of GUTB in India is nearly 18%. The primary site of infection is kidney, and from there it spreads to the lower urinary tract. As urinary TB is having no specific symptoms or clinical features, early diagnosis and treatment of urinary TB has become a clinical challenge for all the healthcare practitioners. I would like to introduce that if a patient is having lower urinary tract symptoms with dysuria, with or without hematuria for at least 2 weeks, not responding to a course of 3 to 7 days of antibiotics with or without constitutional symptoms, we can label the patient as urinary TB and should be evaluated further, even if the patient is having only LUTs. The aim is to analyze the spectrum of clinical presentation, diagnosis, management, and clinical outcomes of urinary tuberculosis, with the objectives being the diagnostic challenges and therapeutic challenges we are facing in the management of urinary tuberculosis. The study is conducted in the Department of Urology, St. Martha's Hospital, Bangalore, between January 2021 to February 24. It is an observational study containing a sample size of 16 with presumptive urinary TB cases. The inclusion criteria is patients with lower urinary tract symptoms qualifying for presumptive urinary TB case. Exclusion criteria will be the lower urinary tract symptoms with obvious causes like bacterial infection, stones, prostatitis, diabetes mellitus, and primary bladder pathologies. Results, patient information, the mean age of presentation is 39 years of age and with female preponderance. The time at presentation, only 6 patients presented before 6 months and 10 patients presented after 6 months, with prior antibiotic usage noted in all the 16 patients, with lower urinary tract symptoms being the most common presentation, which is noted in all the patients as per our inclusion criteria. And 37% of the patients were having flank pain, and 25% of the patients were having constitutional symptoms. Urine analysis was done in all the patients with urine routine microscopy showing pyuria in 75% of the patients and hematuria in 25% of the patients. And urine culture sensitivity was done, which is showing sterile pyuria in 75% of the cases. Urine AFB was done in all the patients showing only 12.5% positivity rate, and gene expert was done, which is showing 43% of the positivity rate. And urine culture for MTB was positive only in 37% of the patients, with urine analysis being completely normal in 12% of the patients. Imaging studies like plain chest X-ray is done in all the 16 patients, showing prior pulmonary TB changes in 31% of the patients, and ultrasound KUB is done in all the patients, showing non-specific features like hydronephrosis, strictures, and reduced bladder capacity. CT urography is done in all the patients, showing thickened urinary tract walls being the most common, followed by hydronephrosis and hydroerythronephrosis and strictures, with others being urinary tract calcifications or cavities, renal parenchymal scarring, moth-eaten calyx, and putty kidney. If a patient is having multiple strictures or single stricture with one other imaging finding, or a putty kidney with another imaging finding except stricture urethra on CT urography, we can label the patient as a presumptive urinary TB case and we can start him on treatment. This is a CT KUB picture showing left side grossly dilated kidney with multiple strictures and thickened bladder wall and reduced bladder capacity, which are features suggestive of urinary TB. This is a classical nephrostogram picture showing multiple strictures, thimble bladder, phantom calyx, and infundibular stenosis. This is a CT KUB post-ATT showing the sequelae of urinary TB with thinned out parenchyma and grossly dilated left side kidney with multiple strictures and thimble bladder. Bladder biopsy was done in 9 patients, out of which 44% were positive. Initial clinical outcomes: out of the 16 patients, 12 patients underwent ureteral stenting at the initial outcome, the initial presentation only, and no surgical intervention was done in 18% of the patients. They were started only on ATT. One patient underwent directly nephrectomy. No nephrostomy or reconstructive surgeries were done at initial presentation. At 6 months of follow-up, repeat urine MTB culture was done, and 4 out of the 6 cultures which were positive initially for MTB were still positive. So the TB regimen was extended in those 4 patients to 8 to 10 months based on the symptoms. None of our patients had any drug-resistant TB noted. At 1 year of follow-up, out of the 16 patients, still 4 patients were requiring ureteral stenting, 4 patients were required nephrectomy, and 1 patient underwent nephrostomy, and 1 patient underwent reconstructive surgery, with only 6 patients being symptom-free at 1 year of follow-up also. Urinary TB is a common disease which is in adults, with time lapse between primary infection and renal tuberculosis with a latency of 3 to 10 years. Renal infiltration is gradual and progressive, involving one or both the kidneys, causing renal failure ultimately. Imaging studies are important in investigating urinary TB. The diagnostic dilemma we facing in diagnosing urinary TB is that acid-fast staining is cheap and fast, but it lacks sensitivity, with only sensitivity of 30% and reproducibility also. In our present study, we noticed only 12.5% positivity rate. And urine MTB culture on special medium has an acceptable sensitivity of 20 to 97% because of the intermittent shedding of the bacilli. It is a time-consuming process and delaying the patient care. In our present study, we noticed only 37.5% positivity rate, which is less when compared to the literature. Bladder biopsy has an acceptable sensitivity of 18 to 52%. In our present study, 44% positivity rate was seen. CT urography has becoming an emerging modality in the diagnosis of urinary TB, with the sensitivity being 87%. In our present study, we had a positivity rate of 87% on CT urography. In drug-susceptible TB, 2 months of intensive phase treated with 4 drugs and 4 months of continuation phase with 3 drugs was the standard treatment regimen, with extension criteria being any delay in the conversion of positive cultures to negative. And the regimen can be increased up to 9 to 12 months based on the symptoms of the patient. And surgery still holds the center stage in the management of urinary TB if the patients are presenting late. In our present study, 81% of the patients underwent one or the other form of surgical intervention at the initial presentation only. Early decompression of the kidney where it is obstructed by the strictures, the salvage rate of the kidney can be increased. The therapeutic challenge we facing is that in spite of ATT and surgical management, 25% of the patients underwent nephrectomy, and 25% of the patients were still requiring ureteral stenting at 1 year of follow-up also. Only 37.5% of the patients are symptom-free at 1 year of follow-up. This is a comparison of my study with other studies showing that urine AFB and urine MTB culture positivity rate was way less compared to the other studies also and compared to the literature also, maybe because of the intermittent shedding of the bacilli and prior antibiotic usage also. CT urography has an acceptable sensitivity of almost 87%, which is comparable with other studies also. Almost 81% of the patients underwent one form of surgery at the initial presentation, which is comparable with the other studies when they presented late. Hereby, I would like to conclude that microbiological tests are still not sensitive enough to diagnose all the urinary TB cases, leading to a diagnostic dilemma. And CT urography has a promising role in detecting urinary TB. However, delayed detection because of the structural changes is an issue. In view of intermittent bacilluria, initiating treatment based on clinical and radiological findings, is it justifiable, is still a question. ATT is not the panacea, and follow-up is essential for the patient to be symptomatic free. The limitation of my study is lack of confirmatory diagnosis and small sample size. These are my references. Thank you.
Thank you, Dr. Subbareddy. The paper is open for discussion.
Good evening, sir.
So you said that urine for AFB was one of the diagnostic parameters which you used. So what timing of urinary sample and how many urinary samples were sent?
We should take at least 3 to 5 early morning urine samples. The best is to collect overnight urine sample and sediment it, and the sediment can be sent for the testing. We can have a high yield of positivity rate.
Yeah, so the basic funda of collecting the first morning sample of urine is because of the intermittent shedding of the bacilli from the kidney.
Yes.
So that is why, of course, it still has a very low sensitivity. And other thing you said that 25% of your patients required ureteral stenting.
Yes, sir.
So what was the timing of ureteral stenting, and what is this class of patients who actually required ureteric stenting?
At 1 year of follow-up also, almost
that is delayed. That is probably post-ATT.
Post-ATT.
Before, when the patient was diagnosed as suspected GUTB,
yes,
25%. This 25% is the ones who required late stenting, or they were stented and they continued to be on stent for 1 year?
They were stented at the
initial. So what was the indication of stenting? That's what my question is.
One thing is, at the initial presentation, there were strictures and hydronephrosis. For the decompression of the kidney, we did ureteral stenting. At 1 year of follow-up, also they are requiring ureteral stenting because of the secondary infections causing kidney damage, or strictures which were already developed, or after starting ATT, the chances of development of strictures will be a little bit more because of the fibrosis during the healing process. So some patients who had bad strictures were still undergoing.
Otherwise, what is the ideal time of stenting? If there is a patient with a small stricture causing grade 1, grade 2 hydronephrosis, however, on DTPA there is no real obstruction, what is the ideal time of stenting?
Ideal time is to do stenting at 6 weeks after starting ATT. If at all any surgical procedure we have to do.
So the ideal time is within 2 weeks of starting ATT, because once the ATT is started, the fibrosis intensifies and the partial stricture may actually converted to complete stricture. And as you said, one more last question. Yes. The suspected urinary tuberculosis in your case was based on predominantly CT urography findings. Yes. So are we still following that major and minor criteria for diagnosing GUTB? The major criteria is positive AFB or PCR or granulomatous lesion shown on. That is actually the gold standard.
Yes, sir.
And the minor criteria is, of course, the imaging findings, MON2s and plus minus. So the teaching during our times was one major or two minor criteria. If they are satisfying, ATT can be safely started.
But in our study, we started these are all presumptive urinary TB cases in which some of them were confirmed by microbiological tests, but majority of them were positive on CT urography, and we have to have a discussion, we want to initiate a discussion that whether based on only CT urography, can we start on ATT? Because majority of our patients who became symptomatic free, they were started based on only CT urography findings.
It's very much justified to start ATT based on purely CT urography findings, because the lab investigations and biopsy investigations takes 10 to 15 days.
Yes.
So if the image is staring at you, shouting that I am GUTB, it is absolutely safe to start off ATT.
Yes.
And if you're doing bladder biopsy, what is the protocol of bladder biopsy?
If a patient is having any thickened bladder wall and if the patient is having classical feature of a thimble bladder, we can, almost all the patients were undergoing ureteral stenting for the decompression of the kidney. So in the patients who were, we don't have any microbiological confirmation or histopathological confirmation. As we are doing a surgical procedure, we took the bladder biopsy for the confirmation of our diagnosis, as CT urography is only for a not a confirmatory diagnosis, it is only presumptive.
Thank you.
Yes, sir.
Thank you, sir.
Yes.
Thank you, Dr. Suparidi.
Thank you.
Yes.
I call upon Dr. Nancy. Here I would like to tell one thing. The original presenter was Dr. Ajay. Unfortunately, he fell ill. His platelets dropped, he was diagnosed with dengue and he had to be hospitalized. This happened just 48 hours back. So Dr. Nancy volunteered to present this paper. She had only 48 hours to prepare. Yes, Dr. Nancy.
Good evening, respected dignitaries on and off the stage, my colleagues. I'm Dr. Nancy. Today I'm going to present a paper on the outcomes of concomitant lateral internal sphincterotomy during open hemorrhoidectomy. As we know, hemorrhoids are the symptomatic enlargements of the anal vascular cushions, mainly at this 3, 7, 11 o'clock is the primary positions. They present with intermittent mass per rectum and painless bleeding associated with bowel movements. They are, based on severity, they are graded from 1 to 4. Grade 1 being present with only bleeding. Grade 2 has prolapse. Grade 3 require manual reduction. Grade 4 is a permanent prolapsed hemorrhoids. After initial diagnosis and evaluation, initial approach can be with conservative management with high fiber diet, laxatives and water intake and lifestyle modifications. Grade 1 to 2 hemorrhoids can be managed on office-based procedures, or some require surgical intervention. Grade 3-4 ultimately require surgical intervention. Some of the office-based procedures are using sclerosants, infrared coagulation, and rubber band ligation. Minimal invasive procedures like hemorrhoidal artery interventions with Doppler-guided ligation, hemorrhoidal artery embolization, hemorrhoidopexy with laser or stapler are also present. Excisional hemorrhoidectomy is of two types, open and closed. In our study, we perform standard open Milligan-Morgan's hemorrhoidectomy on all of our patients. In this procedure, we retract the hemorrhoids by holding the hemorrhoid with an artery forceps, and a V-shaped incision is made at the skin in the anoderm and extended till the pedicle by blunt dissection. The pedicle is ligated and transfixed, and the hemorrhoidal cushion is transected. The bare area is left open. In half of our patients, we perform an additional lateral internal sphincterotomy through the same incision by dividing 30 to 40% of the internal sphincter muscles. This helps in this study is mainly because this LIS helps by dividing the muscle, which helps in decreasing the post-op spasm. Our aim is to compare the effectiveness of lateral internal sphincterotomy with hemorrhoidectomy versus only open hemorrhoidectomy. Our objectives is to compare the following outcome measures: post-op pain at 12 to 48 hours and 7-day post-op, post-op analgesia requirement, bleeding, urinary retention, anal incontinence, length of hospital stay, and return to work. This is a prospective comparative study on a sample size of 50 patients in our hospital over a period of 2 years. The patients are followed for 3 months. These patients are randomized into Group A and Group B. Group A being hemorrhoidectomy with lateral internal sphincterotomy, Group B being hemorrhoidectomy alone. The post-op pain is assessed using visual analysis score, and post-op analgesia, we gave all underwent spinal anesthesia, and post-op we gave injection paracetamol 1 gram IV on the evening of surgery. After that, on-demand protocol and rescue analgesic doses are given. We gave inpatients injection tramadol, and post-discharge tab tramadol and PCT combination SOS. Number of rescue doses 0 to 2 is calculated as mild requirement, 3 to 4 as moderate, and more than 4 is severe. We included grade 3 and 4 hemorrhoids who are more than 18 years and excluded fissure and fistulized ano coexisting, and comorbidities like inflammatory bowel diseases, malignancy, cirrhosis, recurrent hemorrhoids, anesthesia, anything except spinal anesthesia. Our data is entered into Microsoft Excel and analyzed using SPSS. Frequencies and percentages are calculated. Chi-square test is used. Level is significance is set at 0.05. Our final results are as follows. Age, gender, and grade of hemorrhoids is comparable in both groups. Post-op pain at 12 hours, 76% in the group A had mild to moderate pain, while 100% in group B had moderate to severe pain, group A being hemorrhoidectomy with LIS and B being without LIS, which is significant. Post-op pain at 24 hours, 100% in group A had mild to moderate pain, while group B had moderate to severe pain, which is significant. At 48 hours, 92% in group A had mild pain, while in 76% in group B had moderate pain, which is significant. At 7 days, 84% of group A had no pain, and 74% in group B had mild to moderate pain, which is significant. Requirement of analgesia is also found to be significant. Post-op bleeding is not significant. Post-op anal incontinence, none of our patients had anal incontinence. Urinary retention is not significant, but 2 out of 25 had in group A had urinary retention, while 4 in 25 had urinary retention in group B. Length of hospital stay, majority in group A are discharged by post-op day 2, and group B by post-op day 3, which is significant. Majority in group A return to work within 1 week, and group B return to work within 10 days, which is significant. I would like to highlight that LIS decreases spasm of internal sphincter, therefore leads to decreased pain after anal procedures. We have not encountered any complications of LIS in our study. In our study, P value is significant for post-op pain, analgesia requirement, length of hospital stay, post-operative return to work, and it is comparable to other studies as follows. I would like to conclude that hemorrhoidectomy with lateral internal sphincterotomy is better in terms of reducing post-operative pain, analgesia requirement, and leads to shorter hospital stay and early return to work. These are my references. Thank you.
Thank you, Dr. Nancy. The paper is open for discussion.
Very well presented.
Thank you.
Now, you see, the problem is, I'll just put it like this. In a case of fissure, what is the cause of pain?
Due to sphincter spasms.
Exactly. So now you are creating 3 or 4 fissures there, you are taking out the hemorrhoids. So naturally you'll have a spasm. So it's always better. In fact, most of us always do internal sphincterotomy along with hemorrhoidectomy. The answer is very simple. Thank you. Well,
I think this was an old methodology, when I was in St. John's about 25, 30 years back. My boss used to do lateral sphincterotomy for hemorrhoidectomy. Later on, they've done a lot of randomized studies. I don't know whether you looked into them critically. We found no difference between Milligan-Morgan hemorrhoidectomy and the one with added lateral sphincterotomy. So most of us do not follow it, okay? So the reason is that when you're doing Milligan-Morgan, you have to go into the correct plane. You should not damage the internal sphincter, the 3 places, and you add a sphincterotomy. So your likely chances of incontinence being more. And there's a very structured methodology for grading incontinence, which you have not followed. You just said no incontinence. It's not so simple. And secondly, one should do anal manometry before surgery and after to compare. Okay?
Yes.
Thank you.
Thank you, Doctor.
Yeah, it's a long-term follow-up.
Thank you.
Thank you. Yep.
I would...
Yeah, this concludes the paper presentations. I would like to thank the management of St. Martha's Hospital for giving us this chance, encourages us to make these presentations. I would also like to thank the sponsors who have helped us arrange and organize this program. And I would like to thank my department in helping me in organizing this. Thank you.
So to all the postgraduates, the presentations were very well. The slides were neat. And I think they have put a lot of hard work in that. Everybody stuck to the time. Congrats on that.
So it was wonderful presentations, and I would like to thank the judges for today's poster and paper presentation. I would like to, announcement first. So some announcements, and then we'll be calling the judges. One of the most important announcement is I would like to invite Dr. Rajshekhar C. Jaka, immediate past president, who will be handing over.
Actually, the last year was very good under the leadership of Dr. Rajshekar Jaka. We won the best city chapter in the ASICON. So this is the award which we have got.
We got this best city award. It is not just because president or secretary. Everyone in the society helped us do this. So I bow in gratitude and thanks to each and every member, whether it is full-time member or state member, everyone together contributed this. Thanks to everyone.
I thank everyone, the society members, to give an opportunity to work at the Golden Jubilee as Secretary and got the Best City Chapter Award. I thank everybody.
We would also like to encourage the exam-going postgraduates to become full-time members of the Surgical Society of Bangalore with a token payment of only rupees 2,000. It would be very prudent to be a part of this society to be updated with the latest in the development of surgical trainings. I would also like to invite the Saptagiri and MVJ Hospital who will be presenting for the next clinical society meet. So if anyone is there from Saptagiri Institute, to come forward and invite for the next upcoming clinical meet. Dr. Kalaivani.
Good evening, everyone. Thank you, Sreekar. So we are hosting the second month meeting that is on February 19th, along with the MVJ Medical College. So I request your gracious presence for our meeting too, and encourage our postgraduates with your questions and guidance. We'll be very happy for that. So I request you all to please attend the clinical meeting next month. Thank you.
Anyone from MVJ Medical College? Okay, all right. Yeah. I would also like to make a very good announcement. Our own Dr. H.K. Nagaraj, sir, has won the President Gold Medal Award in the recently concluded Urological Surgical Society of India. So very good round of applause. He is a non-tiring person. He keeps on working hard. Yes, sir. Thank you. So I would like to invite Dr. Sreekar onto the dais for judging the posture, sir. Judges. Yeah. Ahead. Thank you, sir. Yeah. Also, I would like to invite the judges for the paper presentation, Dr. Arun sir and Dr. Hemant, onto the dais, please. Bani, sir. Thank you. Announcement. Mantha sir, ready? Yeah, we'll shortly announce the winner. We'll just announce the winner. Okay.
We have sort of improvised on the certificates also.
So you're getting the new certificates for the winners. So it should be very attractive for you guys to see the certificate also.
Yeah, I would like to take this opportunity to thank the President and the Secretary. I would request you to accept our token of affection, please. You can.
Yes, sir. So, yes, sir.
Dr. Sreekar. Sreekar.
I would like Dr. Sreekar. I would like to ask Dr. Sreekar sir, who was the judge for the poster presentation, to call upon Dr.
Nandan Hegde.
Yes, sir. Yeah. So what was the topic? Oh, it was on forgotten. Yeah. Yeah. Oh, okay. Yeah. Yeah. I would like to ask Dr. Arun from ESI Medical College to present for the second prize. The paper.
The second prize goes to Subbareddy Mallan.
The topic is urinary tuberculosis, the challenge. Yeah. Sorry. The first prize, I would like to ask Dr. Hemant from ESI Medical College to present it to Dr. Bhumi Reddy. The topic is IPOM versus ETEP.
After the national anthem, I request you all to join us for dinner below. Thank you.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे